Good morning, all. We're going to go ahead and get started. Good morning. I am Lindsay Denny, Health Advisor for Global Water 2020. On behalf of Management Sciences for Health, Frontline Health Workers Coalition, and Global Water 2020, we are pleased to welcome you to this UN General Assembly side event, Stopping a Global Pandemic Without Water, How WASH is a Neglected Critical Element of Health Security. We have an exciting session lined up for you all today with a panel of distinguished experts in the field of global health security and WASH. However, before we hear from them, let us first revisit the UN Secretary General's statement last year on the important role of WASH in health, in line with the World Health Assembly and subsequent stakeholder commitments, in a video produced by PATH.
I'm pleased to address your gathering. 1 in 4 health facilities worldwide lack basic water. 1.5 billion people use facilities with no sanitation. In the least developed countries, 17 million women give birth annually in health centers where they and their newborn babies are at risk of infection, disease, and death. The provision of safe and clean sources of water is a necessity for human survival, yet it has never been at a greater risk. Together, we can solve this crisis. Thank you.
The Secretary General's words take on a greater sense of urgency now in the face of COVID-19. Hand washing is critical to prevent the spread of disease. Yet communities around the world are without soap and water. Billions of people are forced to visit healthcare facilities where health workers cannot practice basic infection prevention and control. This neglected crisis has not been a priority in global health security efforts, which has weakened pandemic preparedness and community resilience. So today, we will focus on the role of WASH in prevention, and here with us to start the event is keynote speaker, Laurie Garrett. Garrett wrote her first best-selling book, The Coming Plague, Newly Emerging Diseases in a World Out of Balance, while splitting her time between Harvard School of Public Health and the New York newspaper, Newsday. In the 1992-1993 academic years, Garrett was a fellow at Harvard, where she worked closely with the Emerging Diseases Group, a collection of faculty concerned about the surge in epidemics of previously unknown or rare viruses and bacteria. The Coming Plague became a New York Times bestseller, and for her reporting on Ebola for Newsday, she was awarded the Pulitzer Prize in Exploratory Journalism. Garrett is a member of the World Economic Forum Global Health Security Advisory Board. She is also a member of the Council on Foreign Relations, where she created the Council on Foreign Relations Global Health Program and served as Senior Fellow for Global Health from 2004 to 2017. Garrett has written numerous books and articles on public health and health security, becoming a global health authority on infectious disease and outbreaks. Laurie, I turn to you.
Thank you very much. And greetings to everyone who is joining us today. This is such an urgent and obvious, a classic example of a low-hanging fruit problem. We know without clean water and soap, you don't have hygiene. It's just A plus B equals C. When I walked into the Kikwit General Hospital in 1995 in the middle of the Ebola outbreak, I was stunned that there was no water at that hospital, and that the way they sterilized instruments between surgical procedures was in a giant cauldron over a bonfire, simply boiling them for whatever amount of time was possible before using them on a patient. The doctors themselves had no way to wash their hands. And so, not surprisingly, Ebola in that region was primarily spread within hospital settings, within the very settings that are meant to save lives. All over the world, we see that roughly 16% of healthcare facilities lack any serious, clean running water, which is absolutely an astonishing finding. SDG number 6 would have addressed this, but here we are in a magnificently enormous recession, pandemic, global economic crisis. And because of this crisis, and here we are virtually meeting instead of in the hallways of the United Nations, we are all hard pressed to address any great visionary tasks right now. Money is scarce, solidarity is even scarcer. and whether SDG 6, bringing safe water to the entire world population, will be realized as anybody's guess. Right now, it doesn't look promising. Some 3 billion people simply can't wash their hands. So the very pandemic that is putting all our efforts in peril because of the lack of solidarity and a lack of resources is spread because of the problems we can't address. Hand washing. And of course, it's more than just water. You can't get rid of the COVID SARS-CoV-2 virus without soap. So lacking water also must mean, do we have soap to address the problem? About half of school children around the world are probably not in classrooms right now because of COVID, but half of those who are in classrooms are in schools that lack any hand washing facilities for those kids. As we look around the world, we can see multiple disease crises affected by this lack of appropriate hand washing capacity and safe water for hygiene. It's not just COVID, it's cholera, it's Shigella, it's influenza. It's a long list of diseases. We cannot address health security and improve the survival of humanity and decrease the threat of pandemics if we fail to deal with this crucial hand washing crisis. According to the WHO UNICEF Joint Program for Water Supplies, Sanitation, and Hygiene, 4.2 billion people have no access to water for sanitation on a routine basis. 3 billion can't even get their hands into a designated hand washing facility to appropriately sing happy birthday twice while scrubbing their hands with soap to kill the COVID virus. Even here in the United States, the richest country on earth, 2 out of every 5 urban residents are unable to pay their water bills and ensure that they have safe water to wash with and drink in their homes, because our water bills have increased by an average of 80% since 2010. All over the world, we're seeing water scarcity, that the cost of water is higher, not just a financial cost, but a distance cost for children to walk in order to collect water and bring it home on their heads. A cost in lost school time for those very children, a cost in agricultural time as you try to rationalize which water goes to feed the crops, which goes to clean the homes and the children. All of this means that this conversation is absolutely paramount. You can't stop a pandemic if you don't have the ability to clean your hands. I welcome this conversation and congratulate the organizers for bringing it to the attention of the United Nations and the entire global community that is able to observe this at this time. Thank you very much.
Thank you so much, Lori, and your words could not ring more true. In particular, you know, we had thought about doing this event in April, and you were invited to this, and we know that when we planned this in February, you told us that wouldn't happen, and how right you were. So we are in a serious circumstance, and we really value your time and your focus on this issue. Thank you.
Thank you.
We will now turn to our panel discussion, moderated by Dr. Jennifer Nuzzo. A quick note about the Zoom platform: there is an opportunity for questions from participants during the Q&A portion of the panel. You can submit questions at any point during the discussion via chat box. Please make sure everyone sees your question by selecting all panelists and attendees. So now I turn to the panel. Dr. Nuzzo is a senior scholar at the Johns Hopkins Center for Health Security, an associate professor in the Department of Environmental Health and Engineering and the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. An epidemiologist by training, her work focuses on global health security with a particular emphasis on outbreak detection and response, health systems as they relate to global health security, international and domestic biosurveillance, and infectious disease diagnostics. She directs the Outbreak Observatory, which conducts, in partnership with frontline public health practitioners, operational research to improve outbreak preparedness and response. She also co-leads the development of the first ever Global Health Security Index, which benchmarks 195 countries' public health and healthcare capacities and capabilities. their commitment to international norms and global health security financing, and their socioeconomic, political, and environmental risk environments. Over to you, Dr. Nuzzo.
Thanks so much, Lindsay. I'm very happy to be participating in this important discussion. The relationship between water, sanitation, hygiene, and health security is a topic that's very important to me. I actually have a personal connection to this topic as I entered the field of health security at its intersection with WASH. I didn't do this work abroad, as you may think when you hear of the topic of WASH, but actually here in the United States, in New York City, in fact. I was an epidemiologist working for the city, working to ensure that people weren't getting sick drinking the city's public water. People rave about the drinking water in New York, and it's thought to be one of the reasons why New York's bagels and pizza are so famous. But the high quality of drinking water in New York City is the result of a lot of hard work, aggressive environmental protection, team of scientists and technicians who are constantly working to ensure that the water is safe to drink and that our sanitation systems are working as they're supposed to be to prevent contamination. And that was really what I was doing as an epidemiologist. But my work took on a new dimension with following the terrorist attacks of 2001. After 9/11, there was a very real concern about deliberate contamination and interruption of New York City's water supply. And so what had initially been described as sort of a small portion of the work that I would do, the idea that we could be using our surveillance systems to detect the potential deliberate contamination of the city water supply. When I had first heard that in my job interviews, I thought that sounded like science fiction, but clearly after September 11th, it no longer seemed that way. Really, I think what September 11th did was not only give rise to this field that we now talk about as public health preparedness, really galvanize work in that area, but for me personally and for many others, it really helped put our critical dependence on water and sanitation into a new light. When you're threatened with the possibility of losing it or harm, you can really see how devastating that would be. We know, of course, that the rest of the world is not nearly as well defended against threats to WASH as places like New York are. And as we've heard, this is having enormous public health consequences, with billions of people lacking access to safe water and nearly that accessing sanitation services. We're seeing 300,000 children under 5 dying from preventable diarrheal diseases each year. This is clearly a public health emergency on any day, but certainly in the context of an ongoing pandemic, we very much see the intersectionality between WASH and disease prevention. And I think Lori gave a very compelling example of how the absence of WASH can really lead to outbreaks, particularly in health facilities, and how when these outbreaks happen, the inability to use health facilities as a way to interrupt transmission can serve as an amplifier of overall community spread. This can turn outbreaks into epidemics, and if epidemics aren't contained, they lead to pandemics. So I'm very happy that we're having this conversation today, and we're going to hear from 4 excellent panelists. I'm going to introduce them individually right before they speak, and then we'll have some time for questions from the chat box, as was mentioned. First, we're going to hear from Margaret Odera. Margaret is a community health worker and mentor mother at Mathare North Health Center, which is located in Nairobi, Kenya, where she lives. She spends her days mentoring HIV positive mothers and mentoring their progress to ensure no transmission of HIV from mother to child until the baby reaches 18 months of old and is HIV free. As an HIV positive person with an HIV negative husband and 3 HIV negative sons, Ms. Odera serves as a role model for how women living with HIV can thrive with access to essential health services and education to ultimately lower their HIV transmission rate to 0. So with that, we'll hear now from Margaret. Margaret, do we have you? Great. I see you now, and I think you're still on mute.
Yeah, Margaret, you can unmute yourself, and then Jen, maybe we just give her the question straight after that,
Alright.
make it easier.
Okay, thank you so much. Access to WASH is very important to me as a community health worker and a mother living with HIV, as well as women I work with in my community to prevent mother-to-child transmission of HIV. And the WASH protects immunocompromised people like me and others in the community from diseases. And
Margaret,
for us,
I'm sorry to interrupt. I'm having a hard time hearing you, and I see some other faces maybe as well. I wonder if there's a way to get closer to the microphone.
okay,
Oh,
all right, thank you so much.
great.
Thank you so much. Yes, access to WASH is very important to me as a community health worker and mother living with HIV, as well as the women that I work with in my community to prevent mother-to-child transmission of HIV. WASH protects immunocompromised people like me and others in my community from diseases. For us, safety is a big issue, and because we are immunocompromised, this is really a concern for us. Over the last few months, COVID-19 and ongoing worker strikes in Kenya related to COVID-19 have drastically affected access to WASH in my facility. Example, like last week, there was no access to clinical, or there was no clinical officer, there were no nurses in the facility. So the stores were closed, and the stores were closed, and we had no access with the medicines to just even treat the water tablets, and even the access to soap and water treatment tablets and detergents and laundry for community health workers like me was not there. So there has been no sanitizer in the facility for the last 2 months right now, and so I don't have any sanitizer provided to me to carry when I go to the community to do my work. So I must buy myself a sanitizer just to keep myself protected. And because I'm still a volunteer, it is not sustainable for me. Then in Mathare, where I live and work and conduct home visits, we also have non-sustainable access of clean water. There is an acute shortage of clean water. There was a time even my friend came to visit us in Nairobi. She could not even wash her hands because there was no water. My friend Carol Ballis came to visit, and there was no water in our blocks. So it's really a concern for me and also my children as a mother myself. Although we have a new borehole in the facility, there is no plan for a borehole in the community at all. So we still have that, there is no sustainable water system in the community. And right now in Mathare, I pass through open and blocked sewer systems in several streets and blocks on my way to and from the facility. I cannot get even to the homes to see the people whom I visit to mentor the mothers because of the sewer system, the bad sewer systems. So I have to stand across, and they have to stand far, and this affects even that secret that I have to keep for them. It really affects me and those HIV mothers. So I have to stand across from open sewages, and some mom cannot even come out to talk to me openly because of the stigma. They will have they'll be stigmatized. So that is also an issue for us. Then the diarrhea in children is on the increase in Mathare. In September, even today, as I got out of the hospital, I referred a child who was having an acute diarrheal disease in the hospital. So in September alone, I have referred 27 children who are under 5 years. And this is really a concern for me. Then we don't know when the strike is going to end, because some of the nurses, even right now, are still on strike, even today as I speak to you. Although COVID infection
Did we lose you?
rate is diarrhea infection is us in the eye. So my bottom line is this: not having access to clean water and adequate wash in health facilities is not only a barrier. It is not only a barrier for being able to treat people. It is also a risk for health workers. So we can help access to wash to protect ourselves, so we can help more people. We can't lose any more health workers right now because of COVID, because we don't.
I think we may have lost your sound there. Okay, well, given that, perhaps we will turn to our next speaker. Thank you, Margaret. If you can hear us, I really appreciate your sharing your views as a frontline health care worker in terms of the critical role that WASH plays in your community and in the facilities where you work. Next, we'll hear from Ann Poya. Dr. Poya is a public health nurse midwife and Fulbright scholar with a doctoral degree in health policy planning and research, with a clinical role in maternal and infant health from Catholic University of America. She's worked for over 38 years in the Malawi Public Health Services in positions ranging from nursing midwifery practice to education, management, and policy. She currently serves as I think it's actually, she's in the chief of party at the USAID funded organized network of Everyone's Health, ONSE, activity in Malawi to achieve improving access to priority health services, as well as reducing barriers to the delivery of priority health services. In addition to her current work, she's also the president of the Midwives Association of Malawi. Dr. Poya, if you will, we know that hand washing is the first line of defense for outbreaks, and we've heard that quite well from Laurie Garrett, especially when you're dealing with a novel virus and no vaccine yet available, as we are right now with COVID. But given that billions of people are without access to soap and water, what are you doing to address this gap in access, and how do you make sure this is maintained through the pandemic?
Thank you, Jennifer, for the question. First of all, I would like to thank the organizers for inviting my organization, Management Science for Health, to participate in this panel. As a issues of wash, definitely allow not the work that I do, because we realize that with water and sanitation,
Dr. Poya, I'm sorry to interrupt. Your sound is cutting out. It might be helpful if you can actually turn off the video. It sounds like a bandwidth issue. I'm sorry to not be able to see you as you speak, but we're having a hard time hearing you.
Okay, I've tried to turn off the video so that if that can improve the transmission.
It does, thank you.
Yeah, okay. Yeah, like I was saying that as a nurse midwife, issues of wash are paramount to delivery of health services, especially in my organization, MSH, is implementing a USAID funded health activity. We've been doing issues of wash since the program was started in 2016, because one of our efforts is to support the Malawi government to address issues of child mortality, including maternal and neonatal poor health outcomes. So since the beginning of this program, we've been doing issues of wash to make sure that people have access to safe water, as well as a good sanitation. Now, with the emergence of COVID, what we've done in the program is to scale up our activities to make sure that the issues of wash are high on the agenda. Now, within the scale up of the wash activities, we've done a number of things, basically aiming at two interventions. The first intervention has been to strengthen IPC wash in healthy facilities. In this, we have accelerated implementation of the clean clinic approach. So what we have done in this setting is to make sure that we have supported the government, basically in the rural health centers, to make sure that their water system is functioning. Because when the program started, we noticed that health centers that had piped water, they had no access to water simply because the reticulation system was not functioning. So we've spent a considerable amount of money making sure that the reticulation system is back in place. So we have basically worked in more than 40 health centers to make sure that their water system is back and running. But we also realized that there are some health centers where they don't have piped water. So what we've done for these facilities, we have provided them with the buckets. These are 200-liter buckets that can be used for water storage, so that both the patients and the midwives and any other health worker that is working at the facility, they are able to wash their hands and able to clean their equipment and sterilize properly. We have also provided chlorine for cleaning and also soap for hand washing, because we know that sometimes government facilities are short of the basics like water, even soap to wash hands. So that's what we have managed to provide. Apart from the water storage, we have also provided hand washing facilities. As you can see the picture in front of us, we have provided buckets that have taps so that both the patients and the health providers can wash hands. So this has really become very helpful, because in every ward, even outside at an outreach clinic, people are able to wash their hands. We have also been able to empower supervisors at the health center level so that they can supervise implementation of IPC wash standards, which were developed by the government with support from our program. The second part of our intervention is to strengthen the community structures so that they can also take charge of issues of wash, including hand washing and any other preventive measures that have been put in place. So the first structure that we have worked with, these are the health center management committees. These are committees that have been put in place to monitor functionality of health centers. Now this time they have been given the authority and the power to see that issues of wash are not neglected. In addition to this, what we have also done is to repair boreholes in the communities, because at one time government had a program of sinking boreholes that people can access clean water, but some of these boreholes were broken down simply because the maintenance culture is not that high in the country. So we have repaired about 220 boreholes in the community, so that now people are able to access clean water. Secondly, what we have done is we have integrated WASH to our program of supporting communities to build improved latrines. The teaching is that after you have used the bathroom, you need to wash your hands. But if you don't have water readily, you are likely to forgo this behavior. So what we have done is we have put in a makeshift tap next to the bathroom, so that when people come out of the bathroom, they can wash their hands. So this is a bottle tied to a pole of a tree, so which can be operated by your foot, so that afterwards you can wash your hands. So these are common in the villages where we have put in improved latrines. But we have also engaged other community structures. These are like village health committees, area development committees, to take charge of disseminating information to their subjects in terms of hand washing and also proper use of safe water. Communities listen to their chiefs. So when chiefs come up with these messages, they're likely to listen to them than if I go there to talk to them. So we have found that engaging the community structures is a good way to make sure that behavior is adopted without a lot of question. The last part in this area is working with the water borehole committees, because wherever we have repaired the borehole, we have put in a committee that takes care of the hygiene, but also they talk to their fellow women, men that are using the borehole to wash hands and to make sure that if the borehole is broken, there is somebody at the community who can repair it for them. So we have also noted that this is an important component of making sure that WASH behaviors are adopted at the community level. Now, to support all this, we have done massive dissemination of information at community level by using multimedia approaches, such as using the print and electronic media. We use local radios. We use village theaters that can go there and preach the news of hand washing to everybody. So far, we have reached nearly about 2 million people with COVID messages that are basically looking at issues of hand washing. You can see the young man in front of us, an outreach clinic in a community where people are learning how to wash hands. And we believe that to sustain this behavior, the committees at the village are the best people that we can use to do issues of wash. So we think we are on the right track. And if we continue to work with the communities, empowering them, they will be able to take care of themselves. Thank you.
Great. Thank you so much, Dr. Poya. I really appreciate it. Now we will hear from our next speaker, Serena Vinter. Serena is the Deputy Director for Strategy, Policy, and Communications for the Center for Global Health at the U.S. Centers for Disease Control and Prevention. And in this role, she leads the CDC's global strategy to engage with key stakeholders, maintain CDC's brand globally, and enhance country office and partner country capacity. Our teams work on government relations, policy development, communications, media engagement, multi-sectoral partnerships, and multilateral relationships to raise awareness of CDC's global health programs that improve life for hundreds of millions of people every year. Prior to joining CDC, Serena spent 6 years working in the non-governmental organizations, including the Trust for America's Health, the Center for Communication Programs at Johns Hopkins, and Management Sciences for Health. So Serena, just maybe kick it off by asking you, part of CDC's role is to provide technical support to countries as they develop global health security action plans. And specifically, what role do you see WASH playing in GHS action plans, both in terms of strengthening the response to an imminent threat such as the pandemic that we're in, as well as long-term sustainable preventative measures?
Thanks, Jen, for the question, and thanks to the organizers for today's session. Good morning, good afternoon, and good evening to everyone who's joining today's session. I think this is a really great question. You framed this in sort of CDC's role to provide technical support to countries, and I think just to restate that is CDC's, focus. We're a scientific and technical agency, and we bring that expertise to a myriad of public health challenges at home and domestically in the United States, as well as abroad. And this includes global water, sanitation, and hygiene. The global health programs that we implement are carried out by more than 1,700 staff working in nearly 60 countries, as well as by scientists, doctors, laboratorians, risk communicators, and other technical experts working from Atlanta. We don't do this work alone. We partner with other U.S. government agencies like USAID, with multilateral organizations like PAHO, and of course with our host country partners through Ministries of Health. And so this concept of sort of global health security and how it intersects with WASH, this term global health security has been very much in vogue the past 6 years or so, but I don't think the concept is new. I mean, we know, I think intrinsically, that no one country can truly achieve health security for its own people unless all countries are able to provide that for their people. And this current global pandemic that we're all living through clearly illustrates that we're all vulnerable to an infectious disease threat anywhere. So with the launch of the Global Health Security Agenda in 2014, there really was an opportunity for nations around the world to reaffirm their commitment to tackle infectious disease threats through targeted investments in core capacities. And while WASH is not a standalone action package, that's sort of the buzzword for, or the jargon for these core areas that they focus on, I think there's an argument that can be made that it is an essential foundation to many Global Health Security Agenda activities, particularly thinking about the role WASH plays in infection prevention and control of disease. And then, of course, the core public health capacities that the Global Health Security Agenda aims to strengthen can also support WASH interventions. I think what CDC brings to the table in terms of that intersection of WASH and global health security is a long history of responding to waterborne disease outbreaks, from cholera to typhoid fever, dysentery. And the work that we do in this space really relies on some of those core public health skills: enhanced surveillance and disease reporting, strengthened laboratory systems to diagnose whatever pathogen is causing the disease, training workforce to carry out outbreak investigations. And of course, all these skills are leveraged to detect, prevent, and respond to outbreaks, whether they are waterborne or other. And I think that we also have heard from the speakers today and from our keynote speaker, Lori Garrett, that even with public health threats that are not waterborne, WASH is a critical component. The current COVID-19 pandemic has really raised the importance, once again, of the role WASH plays in healthcare facilities and communities, especially around hand hygiene, as both Margaret and Anne have very well addressed. And I think there's a need to go beyond messaging around hand hygiene and really ensure that the mechanisms are there. You know, as we've heard from Dr. Poya and also from Margaret, if there is no running water, if there is no access to soap, how can one practice hand hygiene? So what we've been doing at CDC in some of our global COVID-19 response work is supporting WASH in healthcare facilities and hand hygiene in schools and communities. There are teams that CDC has on the ground in countries from Haiti to Uganda, Kenya, DRC, Bangladesh, and they're developing specific activities to strengthen WASH in healthcare settings as part of the overall response activities. And you know, Bangladesh is a good example of that work, where we've been focused on supporting the government and the work to create a healthier environment in the Rohingya camps in Bangladesh. So that includes water quality monitoring, the training of the laboratory staff on water testing, which again is critical, disinfection of water. And so that's a collaboration. It's not, you know, CDC doing it alone. We're obviously working with key partners like UNICEF and the government. And you know, this isn't, you spoke to this also at the beginning of your remarks, Jen, that this isn't just a problem that we say is elsewhere. This is a problem in our own nation. And I think what we've seen in the United States is lack of access to safe running water has led to spread of COVID-19 among some of our tribal populations, for example, the Navajo Nation. And so that's been a big priority and a focus of the domestic response here. You know, as we look ahead to the Global Health Security Agenda, which has been sort of renewed through 2024, you know, I think we can ensure that WASH is better incorporated into that framework. We think that, you know, WASH is not just about preventing waterborne diseases. We've heard here today that it will strengthen prevention and response efforts across a wide range of infectious diseases. I think WASH could be considered an intervention in you know, sort of the non-pharmaceutical intervention category. It could be part of the public health response. We can think about sort of the intersection between public health and environmental health that you spoke to very nicely. I think that could be something that we look at through workforce development. We've spent a lot to train sort of the epidemiologists and the public health frontline workers, but what about sort of the environmental health workers? Can we bring them into the workforce training piece? And then I think just recognizing that one of the stated goals of this new commitment to the Global Health Security Agenda is really looking and bringing in a true multi-sectoral approach to this. This cannot just be ministries of health and health partners working on this. It really needs engagement from a whole range of sectors. And I see some questions in the chat about, you know, how to finance some of this. And I think ministries of finance need to be part of the conversation, the World Bank, and thinking how we look at Global Health Security Agenda and maybe some other initiatives, including WHO's focus on primary healthcare and universal health coverage. So I think there are ways to definitely bring WASH in and ensure that as we build global health capacity to better prevent, detect, and respond to infectious diseases, that WASH is there as part of the solution. So thanks for the chance.
Excellent. Thank you so much for sharing those thoughts. Now we'll turn to our last panelist, Marcelo Cork. Dr. Cork is the Chief of Climate Change and Environmental Determinants of Health Unit at PAHO, the Pan American Health Organization. He joined PAHO in 1998, where he worked as an advisor in environmental public health and provided technical cooperation to senior government officials in the US-Mexico border region, Colombia, Peru, Venezuela, and at PAHO headquarters in Washington, D.C. Before joining PAHO, Dr. Cork was a senior analyst at the Independent Project Analysis, Inc., and as a project manager and senior analyst at Sonoma Technology, Inc. Thank you, Dr. Cork. Maybe I'll just start off by asking you the question. Given the worldwide threat of COVID-19, and we know Latin America, has in the world been hit particularly hard. It'd be helpful, if you're able to provide examples of what's working in Latin America and what more is needed, or challenges that countries may be facing within the region to address inadequacies as WASH, particularly given the ongoing pandemic.
Absolutely, and thank you very much, Jennifer, for your question, and thank you to the organizers for the opportunity to present today the situation in Latin America. Being maybe the last in the panel gave me the opportunity to expand on Latin America a little bit, but at the same time, after listening the amazing experiences from Margaret, from Anne, different perspective, and also from Serena, that really pretty much Serena took my whole role, giving from the CDC perspective, but also the global perspective. So congratulations to the other panelists. I think that they have been wonderful to set the tone on really the importance of washing healthcare facilities. So let me tell you a little bit about Latin America, specifically on experiences. Definitely COVID-19 brought to light two things. Definitely deficiencies that we all talked about, but at the same time, solidarity and opportunities and actions that they were very creative by governments and how different governments acted in different ways. I think that different speakers already talked about the deficiencies, and probably those are not different in Latin America. Definitely the deficiencies are really the differences in population, the access to clean and safe water between urban and rural populations. Also within the urban areas, as you know very well, there are major cities in Latin America when we talk about Rio, when we talk about Sao Paulo, we talk about Lima, where the differences in the population, economical difference means that some lives in shanty towns, or what we call favelas in Portuguese, and other people that they have. So those differences definitely on the access to clean and safe water, sanitation, and soap have made a big difference. However, at the same time, local governments, and in many cases national governments, had taken very creative and actions in solidarity of the population to move forward with certain measures due to the COVID-19. For example, in those countries that they have access to water through national systems or through local public systems, those public companies and even the private companies, they suspend the payments so people do not have really shortage of water if they have. So in that case, they did not have to really think about that because they could not pay because either they lost their job, that the payments were not really, that the lack of payment will really cut their services. So that's an example. Other examples is in the shanty towns. Immediately local governments started to put sinks in order to people have more access to locations for washing their hands, and to really do it all over the different informal settlements. For example, in the favelas in Rio, the local governments have included that with soap and tried to help the population. Other measures that they were taken, they're trying to assure that the quality of water was better than it ever has been. So the residual chlorine, for example, that there are in different facilities, that was up to the emission standards and to the emission standards that they really should be in the healthcare facilities as well as the population. So on one hand, definitely we've seen these deficiencies, and on the other hand, we see that it's possible if we work together and if we really do a more of an integrated job to really move forward towards the SDG targets of 2030. It's not impossible, and even COVID-19 may have made a situation that we have to go back a number of years. Maybe we can push forward faster than before because it's shown that there exists solidarity in governments, because exists also an intention from governments to move forward. I think that the lessons learned so far from the past 6 to 8 months overall, and with those words, I finish also my section of the presentation, is that first of all, we need to be very careful that the solutions are really people-centered. Means that we really need to understand the needs of the population that we're talking about. Not one size fits all. And the needs of the population, they really need to be taken into consideration. Like we said before, the needs of a population that they do not have enough money to make the payments to the water is different than the other populations. They all need definitely the access to safe water. Second, to understand the context. We cannot say and give guidelines that they will say, wash your hands with water and soap, when at the same time we know that in certain areas they don't have neither water nor soap. And therefore we need to be very sensitive to really the context that we're talking about, and not say, for example, rural areas that they may have not access to pipe water, and the facilities that they may not have access to safe water, the same solution that the facilities in urban areas. Maybe in certain rural areas, we have to really learn to tell, collect rainwater in a safe manner, that you have it all the time, or really try to have systems for underground water that are really safe and we can help you with that, and different solutions in their urban areas. The third component is, and Serena talked a little bit about that, is solutions need to be comprehensive. We need to stop having silos in public health. Public health and healthcare services, we are renowned for silos. We are renowned to work really that we have the control and prevention of a disease, one disease. It's really crazy. I mean, we are renowned to know that healthcare services, we just work on healthcare services. On this one, we are all together. And Serena put it really well. WASH should be part of the dialogue of these solutions. How we can get part of the dialogue with a common language. We all need to listen sometimes more than talk. We all love to talk, we all love to say how we're going to save the world, but we learn from the countries that at the same time we need to learn and observe the needs of prevention and control of diseases, and observe the needs of healthcare services and healthcare facilities. And at the same time, healthcare facilities and prevention and control of diseases need to understand how WASH is an integral component of all these solutions and how can be provided in a sustainable manner. And last but not least, we need to be preventive. We cannot really continue putting band-aids to solutions that they will not be sustainable in the future. And we need to think about not only in short term, like we are thinking now with COVID, but use COVID to really think on medium and long-term solutions. And last but not least is that, yes, we need community empowerment, and Margaret were fabulous about showing that, how community empowerment is crucial. At the same time, we need protection. So the delicate balance between protection policies from government, that they really protect the population, that they really consider that water is a human right, that sanitation is a human right, and that health is a human right, and therefore washing healthcare facilities should be a human right, goes hand in hand with community empowerment. So thank you very much for your time, and thank you for the opportunity again to participate in this amazing panel. Thank you, Jennifer.
Thank you so much. I really appreciate those remarks. Now we're going to turn to a question and answer session. I see that people have been populating the chat box with questions, which is really excellent. I'm just going to try to do my best to get to some of them in the time that we have here. I guess the first question, maybe I'll ask of you, and it's been asked, what solutions exist in health facilities in arid areas or semi-arid areas when the dry season is long, referencing that the ability to collect rainwater in these areas may be limited. What can we do to ensure access for the entire year?
Thank you, Jennifer. I think in our terms here, even when it is the dry season, if a health center has been provided with a borehole that is either solar powered it does produce the water the whole year round. So those are the things that we need to capitalize on. But you have also just mentioned here that we need to be innovative. And I believe that if we can support health facilities to harvest rainwater and keep it, it will assist them to go a long way. For example, right now, Malawi will be going into the rain season. And we do actually get heavy rains that run up into floods and all that. So if we can harvest all that water and store it at the facility level, that will be important. But the most critical thing is probably to provide boreholes that are solar powered so that they can produce water all the way around. Thank you.
Great, thank you so much. And there's actually a few questions here that maybe I can try to lump together because they really get at how do we ensure sustainable access? Some questions are referencing, clearly there is an urgent need right now in COVID for additional resources. And so we, of course, need to think about how to provide those resources. But beyond just addressing the urgent need, how is it possible to ensure that there are sustainable investments that will continue to function beyond just this acute emergency? There are also questions here about how we get central governments to recognize the need to include resources for this in their national planning and budgeting. But I think some of the questions are, targeting other sources of funding for this. And I'll let any of the panelists who have things to say on this topic weigh in.
This is Anne. I wanted to mention that I think from what Serena had said, she mentioned of all players taking part in issues of WASH. I think now we have learned our lessons that we don't have to leave issues of water to somebody else, but this should be everybody's agenda. So to me, I would recommend that all sectors in development should ensure that issues of safe water access are built into their plans. For example, right now in Malawi, there's a program for rural electrification or building of roads. If we could encourage government that when such developments are taking place in the rural areas, not only to provide the electricity, but also to provide water. For example, they can provide the electricity, but dig a borehole that can be connected to the electricity, then people have access to water. If people are building roads, I know that the people that build the roads, they may be on the road for a whole year or nearly two, depending on how big the road infrastructure is. And people need water to drink. So they should also be drilling boreholes, making sure that when they leave after they have finished their work, they have left some lasting legacy for the communities other than the road to use, but also they have water in place. So my encouragement is to make sure that all sectors of the economy, when they're doing development work, they should include issues of WASH in it, because we know, as mentioned by the last speaker, that issues of WASH has a right to everybody. So we don't only have the right to electricity or to the road, but also water and sanitation issues. Thank you.
Jennifer, if I may add to that. So in our case in Latin America, what we're doing is started a dialogue between the health sector and the national authorities on water and sanitation. So they really start to have a common language to understand what really are the possible solutions for national health systems, at the same time to understand what are the limitations of the water and sanitation sector to provide those types of solutions. So now in about 3 weeks, as a matter of fact, we're going to have a high-level meeting in a forum similar to this one with hopefully as many authorities of health, ministers of health, and national authorities for water and sanitation to hopefully start the dialogue and move forward with roadmaps for the countries to how do exactly the kind of issue of the question that you asked. The roadmap trying to use the 8 steps that WHO recommends for washing healthcare facilities and to move forward in those countries of greatest needs that they really have a roadmap for each of those countries. So that dialogue will be crucial for us. Thank you.
Okay, and to add on that, in Kenya, there is no exact supervision in the facilities. So I would urge, if there is more intense supervision, especially in the national hospitals like Kenyatta National Hospital or Pumwani National Hospitals, where the sanitation there is sickening. And then the supervisions also to be done in the, in the community, at least once in a while. The public health can take a walk and look at the community where there are shortages. I think that will help as far as Kenya is concerned. Thank you.
I think we're coming up at the end of our time for questions, but maybe just one quick question, the extent just which is quick, to Serena, because you haven't had a chance to weigh in. You talked a lot about sort of multi-sectoral efforts and partnerships, and there's a question here of the efforts that are needed. Who should coordinate them? Who should be at the center of those efforts?
That's a great question. I mean, I think that I think that if there could be a convening of, multi-sectoral that really brought together and leveraged sort of this crisis. I mean, I think I respect and appreciate the point that somebody made, that investing and sort of focusing on the urgent needs now because of the COVID pandemic doesn't really look at the long-term problem. But, how can we take this moment, this crisis, this, global pandemic, and leverage that and bring together people who need to be at the table? And so is that somebody like the head of the World Economic Forum, who has that sort of convening power to bring, not only the business sector, but sort of donors and ministries of finance? I don't know if that's sort of the seat of power, because I think what we have seen is that a health issue easily spills over and has this ripple effect. And this pandemic has been devastating for, economies around the world. And that was laid out very clearly in Lori's opening remarks. But these smaller outbreaks that we face every day are devastating to the local communities that they are occurring in, and devastating to the local economies. So, I don't know if this is something that we could look to, the World Economic Forum to sort of lead and convene and then bring that multi-sectoral approach together. But that's just my personal opinion.
Great, well, thank you for that. And I'd like to thank all of the panelists for sharing their experiences and their thoughts. This is clearly a very engaging topic, and I apologize that we didn't get to all the questions. There's some really excellent ones here, so hopefully there'll be a way to engage following this. But now I'd like to address our final speaker, Dr. Vanessa Carey. Dr. Carey is the co-founder and CEO of Seed Global Health, which is called Seed, a nonprofit that focuses on the power of investing in health and the health workforce for social well-being, economic growth, and equity, which transforms countries. She's currently a critical care physician at the Massachusetts General Hospital and serves as the Associate Director of Partnerships and Global Initiatives at MGH Global Health. She directs the Global Public Policy and Social Change Program at Harvard Medical School, where she's focused on the links between security and health. Dr. Carey's work has been featured at conferences, in print, online, and media, including at the Aspen Ideas Festival, the United Nations, the World Health Assembly. She's been on NPR, PBS, MSNBC, Marie Claire, and her work's been featured in the New England Journal of Medicine, New York Times, and The Lancet. Dr. Carey will talk about global health security efforts and how they must integrate into WASH, and how a failure to do so, what we should expect to see from that. So thank you, Dr. Carey.
Thank you very much for having me. Can you all hear me? Great. I was having some internet trouble earlier, and told my microphone didn't work. So good morning, everyone, and afternoon or evening, depending on where you are. That's the beauty of this year's UNGA 75, is that we have this ability to bring people together from all around the world in a way that we never have before, which I think is incredibly symbolic of our global connectivity, our global vulnerability in this moment, but also our ability to come together and to communicate and to share and to strive to find solutions for this moment in time. I want to start by thanking MSH, the Frontline Health Workers Coalition, the Global Water 2020 for organizing this really important conversation. I also really want to thank the panelists for their perspective, their expertise, and for highlighting some of the very key issues that we need to be thinking about. It's interesting for me because I think that exploring the intersectionality of WASH, pandemic preparedness, and health security, we could be talking about it for a long time. This is the crux from everything that happens on the ground to what it means for our big security. It's incredibly important. And I'm very encouraged that it's being discussed and highlighted on the sidelines of this year's UNGA. This is a really unprecedented time. On this 75th UNGA, I don't believe there is another moment where global health security has been elevated quite to the degree that it has on such a level of the global agenda as we are confronting today in the setting of a global pandemic. It's a moment really of recognition and action, and I want to thank you all for bringing your expertise, your commitment, your curiosity, and your questions to bear. It's clear, both as we experience here in the US where I live right now, as well as across the world, that health security is national security, individual security, community security, global security. Health is fundamental not just to our individual ability to survive and to thrive, but to the collective well-being and stability of our nations and communities. As we witness the repercussions of a global pandemic, we see the ripples across all these levels of society, right? And all of them have been shaken by COVID-19 in some capacity or another. But despite the global scale of disruption that COVID has caused, we've also seen that the front lines of health security are within our grasp, literally. Long, I think, a little bit too neglected from central and policy conversations, and I think a little bit marginalized from the health security conversations has been the integration of WASH into these bigger efforts and how it connects from the community to the policy and the governments. And I think one of the questions that was asked by an audience member, I think it was Maggie Montgomery, was sort of how do we have these very direct community pieces that we're working on like WASH, but we're not letting governments off the hook. And I think these kinds of conversations in these settings help us change that. But I think that as we talk about these things, first and perhaps the most critical steps of infection prevention should be woven throughout our pandemic response preparedness efforts, such as these, as we bring these discussions forward. At Seed Global Health, the global NGO that I co-founded and run, and we partner with governments in 5 countries currently to help strengthen the health workforce, has really been our focus. To date, we've helped train more than 18,000 health professionals, actually almost 20,000 now to date. And in the prior 6 months, we have seen that the disruptions of COVID have wrought on both global health programs and essential services in fragile health systems have been enormous. And so our approach actually has always been to do work directly on the ground, to create change in concert with our partners, think about the holistic system in which we work. How do we protect our frontline healthcare workers through various very local interventions? And then how do we take those interventions and work with government to create policies that nurture the work that we're doing on the ground? And we create a positive feedback loop where policy supports our work and our work informs our policy. Well, much has been written about the access to PPE, ventilators, and oxygen, for example, all of which have been quite vital, and all of these things that we've been talking about in our work at Seed. It's interesting though, because at Seed, as we've responded to COVID, one of our first steps we took was actually to support our local partners in Uganda and Malawi to ensure that our partner facilities and campuses have adequate hand washing, water, and supplies to protect patients and frontline providers. So it's about that very community-based integration of security at the individual and community level that have been so critical and part of our pandemic response. Because it's vital that if healthcare facilities are going to be critical on the front lines of our health security, these facilities have to be properly equipped, staffed, and prepped and prepared in the event of an outbreak, but also, frankly, to deal with the pandemics we're dealing with every day, whether it's excessive amounts of maternal mortality, under 5 mortality, whether it's HIV, TB, malaria, trauma, all of these things that we still have to make incredible progress in, despite the extraordinary progress we've made. And WASH capabilities are integral pieces to this readiness, and from my opinion, are very critical, important first steps that we need to be integrating across the board. So my work personally at Seed Global Health has informed my perspective and understanding of the needs of health systems and facilities in low resource settings. I've also seen what is possible when you have these capabilities in place. I actually serve still clinically today as a critical care physician at Mass General Hospital in Boston. And here I've had the remarkable privilege of working in a really well-equipped, top-notch ICU and clinical setting, especially as we've looked at the COVID response. I was working the wards in April and May when Boston was seeing its massive surge, where we surged to almost shutting down basically the hospital except for ICU and critical care and COVID capacity, and really trying to respond to the needs of our community in that moment. And in that role, I've seen the power and importance of isolation protocols, infrastructure investments, and infection prevention capabilities in mitigating the impact of pandemic and enabling the impact of the pandemic and enabling the continuity of services. And I also know these capabilities engender trust among patients, among physicians, nurses, and they help provide the healthcare providers confidence and security, as well as the patients, that there can be a provision of quality care despite the otherwise disrupted clinical context. But while I'm humbled to practice in this kind of setting, I also know very acutely, therefore, what are the unacceptable disparities in healthcare resources around the world today in 2020. Despite these inequities, though, there's one theme that rings universal for me. In my work at SEED and in my clinical service, I absolutely believe that people are at the heart of a health system. And amongst our technologies, our acronyms and frameworks, we can't lose sight of that fundamental truth. They're the advocates, the accompagnateurs, the provision of care, and it's critical that we help protect them, the community they work in, as well as the patients they care for and the communities that they're serving. Pandemics and health security events are times of grave uncertainty, fear, and personal strain. And health security action plans, well-equipped and well-staffed healthcare facilities, these are the tools that we're leveraging, not just to prevent outbreaks, but to reinforce the trust and confidence in health systems writ large. When these foundations are in place, not only are patients and providers confident, and patients can seek care when they need it, but providers can, physicians, nurses, and midwives can provide the highest quality of care knowing that their own wellness and safety are valued, and that community health workers can work in the settings that they need to support the folks that they're caring for, and that whole care continuum can stay intact. We can't underestimate the importance of this trust, both in the context of a pandemic, as well as the durability of a health system when an outbreak recedes. So as we consider pandemic preparedness and security, we have to remember that these investments align with health system strengthening. When we invest in foundational capabilities like WASH, PPE, infection control, infrastructure, training, and the skilled workforce, when these building blocks are in place, not only are we investing in health security capabilities, we're laying the groundwork for strong health systems that can protect health and save lives every day, not just in the midst of a pandemic, but the everyday care that we need to be providing always. Thank you so much for letting me join you today, and thank you for all the work that you're doing.
Thank you so much for those words, Dr. Carey, and really bringing us back to pandemic preparedness in the greater context of health system strengthening. I'm so grateful for all of you today for bringing your expertise and your insight into this critical issue amidst the COVID-19 pandemic. We'll go ahead and close this session. It is being recorded and I will share it around. Thank you all. Please stay safe and wash your hands.